attending my lecture series. Today I am discussing the important topic of diabetes and anesthesia. A diagnosis of diabetes has the same predictive value for a perioperative cardiovascular event as a history of a myocardial infarction. A positive stress test, Q waves on ECG, or congestive heart failure, predictors of death among the diabetic patients included ischemic heart disease, urgent surgery, American Society of Anesthesiologists, physical status score, and hyperglycemia. Diabetes causes the accelerated aging. Thus, the risks involved in the caring for someone with diabetes is similar to those for someone such as who is older, that is, someone who has a much higher physiological age, that is, real age. Hyperglycemia on the day of surgery predict the morbidity among diabetics and increased the risk of neurological complications fourfold. Diabetes affects the oxygen transport by causing glucose to covalently bind to the hemoglobin molecule and alter the allosteric interactions between the beta chains. The altered in hemoglobin, normal hemoglobin, has been shown to decrease the oxygen saturation and the RBC oxygen transport in pregnant diabetic patients. Cardiovascular system, it must also be remembered that diabetic patients are most likely to have silent ischemia. Hence, the preoperative evaluation should evaluate the risk of perioperative myocardial insult and include any judicious use of beta blockers and perhaps the statin therapy. Goals of perioperative management of diabetes mellitus. The principal goal is to mimic the normal metabolism as closely as possible. Avoid the hypoglycemia, which can cause irreversible cerebral damage. Avoid the severe hyperglycemia, that is osmotic diuresis, severe dehydration, disruption of autoregulation. Avoid large swings in blood pressure, blood glucose rather, maintain the blood glucose within acceptable or individualized range. Supply cells with insulin so that intracellular glucose starvation does not occur, preventing ketoacidosis. Prevent or manage the electrolyte abnormalities, hypokalemia or hypomagnesemia or hypophosphatemia. Now come to the neuropathy. Autonomic neuropathy affects the body's ability to regulate the blood pressure, leading to significant orthostatic hypotension. This underlying defect is caused by a lack of appropriate vasoconstriction. Diabetic patients with autonomic neuropathy are at increased risk for intraoperative hypotension, requiring vasopressor support, painless myocardial ischemia and infarction, and perioperative cardiorespiratory arrest. There may be an exaggerated pressure response to tracheal intubation. These denervation may also involve the vagal control of the heart rate. The changes in the heart rate seen with the atropine or beta blockers are blunted in patients with a significant autonomic dysfunction. Diabetic patients with previously diagnosed autonomic dysfunction these are at increased risk for intraoperative hypothermia. Gastroparesis leads to increased risk of regurgitation and aspiration, even after the lengthy period of starvation. The gastrointestinal system. Diabetes affects the gastrointestinal tract in several ways. First, it damages the ganglion cells of the gastrointestinal tract, inhibiting motility, which delays the gastric emptying and overall transit time through the gut. This increased transit time has significant impact on the practice of anesthesia, as in that all along term poorly controlled diabetic patients should be treated as if they have a full stomach. Preoperative treatment with agents that inhibit acid secretion and prokinetic therapy. Neutralize the stomach acid is essential. Universal preoperative prokinetic therapy in all diabetic patients and suggested limiting its use to poorly controlled diabetics. With elevated in the HbA1c values over 9%. Rapid sequence induction may be employed to try to minimize the risk of aspiration. Well, thank you. We come to the end of my lecture series for today. Next time I will come with more information in my next lecture series. Thank you.